session now. Its topic is entitled "A Deep Dive to Enhance Your Cataract Surgery Outcomes." Cataract surgery is the most commonly performed surgery in the human body, and we are constantly driving to enhance our outcomes for the benefit of our patients. And today we have a group of very eminent speakers who are going to take you through some steps: preoperative, intraoperative, postoperative, how to market this. There's all these aspects will be covered. There will be enough time for audience interaction also. So do keep your questions ready. Dr. Gaurav Luthra could not make it to the conference because of some personal reasons. So instead of that, I have requested Dr. Shresh to speak on newer biometric formulae and devices to perfect outcomes. I think getting a perfect biometry is the basic premise to enhance your cataract outcomes, and it's the right way to start off. Over to you, Shresh.
Good morning, one and all. So today, I think even more than perfecting the skills in cataract surgery, which I think most of us are confident in, it's really the outcomes are improving primarily because of the improved formulae and the devices that we're using to measure it. So over the next few minutes, I'll try to highlight the most salient points of these aspects and how we can take it forward. So we've run through various generations of IOL formulae. While the older generations primarily relied on K reading and axial length, it is the effective lens position which differentiates the newer formulae from the older. And that is precisely what is improving outcomes. Because the important goal is to find out where the IOL which we are going to implant in the eye is finally going to rest. Now, this is also not a fixed number, because as you can see from this slide, it's not just that when you have a long eye, you have a large ACD, or if you have a short eye, you have a smaller ACD. Only 70% comply to that norm. Remaining 30% actually have different proportions. That is, the ratio between the axial length and the anterior chamber depth is quite altered. Therefore, determining the effective lens position for each individual eye becomes extremely important for us to get better outcomes. The Holiday 2 and the Haigis were definitely improvements where they started showing various other parameters apart from just the axial length and keratometry, but like preoperative refractive error, the white to white, the preoperative ACD, lens thickness, all of which were being included for the IOL power formulae. The concept was that when we have more variables, the more accurate outcomes that we are going to get when we do IOL power calculation. But I think more or less now, I think we've all moved on to these fifth generation IOL formulae, which is the Olsen, Barrett Universal 2 and Hill RBF. And I'll briefly highlight the salient aspect of each of these. In Olsen, the most important formula or the most important aspect here is the C constant. Now, the C constant is essentially the ratio where the IOL is going to rest in proportion to the entire lens thickness. As you can see here, now if you take this lens thickness to be 100, and if the C constant is 50, that means the IOL is going to rest exactly in the center. Now, this varies depending on the axial length, the lens thickness, and the anterior chamber depth, and therefore predicting the ELP becomes much more superior with the Olsen formula. Dr. Olsen claims that he does not have as many variables as Holiday 2, but it is important to have the right variables than having multiple variables. The Barrett Universal 2 is one which probably most of us are using now, and it is a thick lens formula. And the most important addition to this formula from the pre-existing formulae is the lens factor. It also takes into account the plane of the lens. That is, even when we go in for very low powers in high myopes, when the lens changes from a biconvex to a meniscus shape, the principal plane and the orientation of the haptic to the optic changes. And therefore, the optic tends to push back a little bit and the ELP gets altered. So this lens factor is also computed, and depending on the IOL power, the effective lens position can be calculated more accurately. And this is really an online calculator which is available for everyone. And we have more or less moved on to the Barrett Universal 2 for all patients across all centers. And the entire Barrett suite actually covers the entire gamut of patients. Your post-refractive surgery, post-RK, you have the Barrett TrueK formula. You also have the Barrett TrueK toric calculator, apart from the regular Barrett Universal 2 and the Barrett online calculators. And you also have the Barrett treatment formula. So if you have a residual power, you can go in and input with the Barrett treatment formula, and it will tell you to how much to rotate, whether you need to exchange, whether you can put in a piggyback. All these options are available with the Barrett Universal. Apart from that, in a more complicated case, you can also use something called the integrated K, where you can compute values from different instruments, from 3 different keratometers, using, let's say, for in this example, it's the IOLMaster Pentacam and manual K. And all of these can be used, and the average reading of this is then taken for computation in these patients. The most recent is the Hill RBF formula. Now, the Hill RBF is a complete step away from the traditional formulae, where it entirely uses artificial intelligence and pattern recognition. So, there's a large amount of data which is fed into this calculator using the LensStar equipment, and then subsequently this undergoes adaptive learning. There is still data being fed in, newer versions are coming out. It is continuously evolving and self-organizing. And because these are from a natural population data, it is free of any calculation bias. This is the earlier version of the Hill RBF, where it was optimized for +6 to +30. And subsequently, this is, of course, the online calculator, the RBF calculator, which is available. Now we have the version 3, which really covers almost the entire range from -5 to +34. And apart from the traditional values, it is also showing that values like CCT, white to white, and gender probably have a small role to play as far as the final IOL power formula is concerned. So essentially, to conclude, as far as the formulae are concerned, I think we are all sticking to almost one formula for the entire gamut of our patients, whether it is a Barrett 2 or a Hill RBF. And all these are available as online calculators, and even irrespective of the kind of biometric device you have, you can use any of these formulae. Keeping in trend with the advancement in formulae have been the advances in optical biometry as well. For paucity of time, I'll just explain the more recent advancements with the IOLMaster 700 alone. Essentially, compared to the previous IOLMaster 500 or the LensStar 500, the 700 is essentially a swept source biometry. And the swept source OCTs are now gaining prominence, and all the newer biometers which are coming into the market are all swept source biometry based. And they are able to give us a true B-scan biometry, and therefore you get very, very accurate measurements of the corneal thickness, anterior chamber depth, and lens thickness, which was not as accurate in the previous versions of the previous iterations of the IOLMaster 500 or the other devices. It also has a foveal pit which can be imaged, and this really allows us to know whether the patient is fixating accurately or not. Previously, we had to rely on the patient to fixate. So just giving you a good example where the foveal pit imaging is good, you get very repeatable measurements, very minimal difference in axial length and keratometry, and the exact same IOL power. Whereas this is an example where you can see that the foveal pit is not imaged, and because of this, there is a significant difference in the measurements between two measurements in keratometry and axial length, and this leads to almost a diopter of difference in the final calculated IOL power. This, because of the B-scan and the swept source OCT, measuring the lens thickness accurately gives rise to better effective lens position and anterior chamber depth measurements in the pre- and post-operative period, which was not possible with the IOLMaster 500. This has significantly improved repeatability and outcomes. Also, because of the swept source OCT, there is a greater penetration in these denser cataracts, and very, very few cases you are having to resort to an immersion biometry. Almost the entire gamut of cases we can cover with the IOLMaster 500. In keratometry as well, it has something called the telecentric keratometry, where essentially, even if the observer who's measuring it or the patient is not able to keep their head very steady, the distance between these spots is maintained. So even if there is a little bit of defocus, the area which is being measured on the central cornea remains constant. And as a result, the recordings are more repeatable. I'll just close in a minute. The most recent advancement is the availability of the total keratometry, where apart from the anterior measurements, anterior corneal measurements, you also have the posterior torus fit. So it gives us in separation the anterior keratometry, the posterior keratometry, and the total keratometry. You also have formulae which are now ULIP compatible, the Barrett formula, which is specifically for the total keratometry value, the Barrett TK. You have the Barrett TK Universal 2 as well as the Barrett TK Toric. Now, these formulae are specifically suited for the total keratometry, and you don't require any modification, and they give you the exact IOL power directly, and even the toric IOL power calculations can be made immediately. This has really improved toric IOL calculations in both regular as well as in post laser refractive surgery eyes. And it is not just the Barrett Truque formula alone. Apart from the Barrett Truque TK, even the Haigis TK. So essentially, the different formulae, as when they incorporate the total keratometry value, it has been shown that it is superior to ones which are just measuring the anterior keratometry. You also get angle alpha, angle kappa values. But most importantly, it is these advancements in the biometry devices and the measurements along with the IOL formulae which is giving us the precise refractive outcomes that we desire in our cataract surgery patients today. And with this 5th generation IOL formulae, emmetropia for any and every patient is a real possibility. Thank you so much for your kind attention.
Thank you, Shreyesh, for that exhaustive coverage. Any questions for him? Any practical points that anyone has? You did speak about optical biometry and your choice of Barrett formula, but there are quite a few of us who do not have access to the optical biometers. In case it's an immersion A scan, obviously we assume that none of us are doing contact A scan and say autorefractometer. Do you think they can still get the benefit of these formulae, and how would you go about doing it?
Definitely. It's just that when in the online calculator, it asks you whether the data is provided by the optical biometer or the ultrasound biometry, and you'll have to use the immersion ultrasound biometry and of course use the immersion A constants. But apart from that, there is the outcomes can be quite similar. We have centers where we don't have optical biometer and only immersion is being done, but even there all the premium IOLs, torics, multifocals are all being done with almost similar outcomes to that of an optical biometer. So it's really the advancement in the formulae and the online calculator being available to any and every one of us, which is now enabling us to reach out to these patients.
So even if you have your measurements from the immersion A scan or the autorefractometer, you can go to the ACRS or APACRS websites. There's a drop-down menu, and you can have access to all these formulae and get the benefit of it. And in case you're using that, you have any suggestion as to what A constant they should be using, whether it's an acoustic A constant or a immersion A constant or a optical A constant?
Yeah, they should be using the acoustic A constant. That's what I mentioned, that both the acoustic A constant and the fact that you're using the ultrasound, there is an option for you to use the acoustic A constants in the calculators, and that needs to be entered when you're using an immersion device.
And another point I'd like you to clarify, we go use the Barrett toric calculator as the go-to formula rather than Barrett Universal 2. Would you like to clarify on the logic behind that and why it should be done?
So essentially, especially when you're placing premium IOLs, multifocal IOLs, addressing even lower grades of astigmatism becomes extremely important. So while we just have a glance through our biometry, I actually have some examples. I thought we had less time, didn't show it. But if you even a 0.7, 0.6 on the anterior cornea, because of the posterior corneal astigmatism and even a low against the rule astigmatism can get potentiated by the posterior corneal astigmatism, resulting in a significant toric requirement. You may be surprised to see that even a very small 0.5, 0.6 on the anterior cornea against the rule gives you a T3 model with the toric calculator. So in case you don't input a toric multifocal or a toric monofocal, these patients will have a significant residual astigmatism, which will degrade both their distance and their near vision. So it's important to input all the regular patients into your Barrett toric calculator and then use the IOL as predicted by the toric calculator rather than just the universal 2.
Good. Any other questions for Shreyesh? Partha, would you like to go next? Are you in a hurry? Yeah, just load up. Just load up. I mean, yeah. Um, I think as far as biometry, as we already emphasized, is the most important aspect as far as uh, the basic premise of the workup of the patient is concerned. Are there any preoperative measures that you would adapt before doing the biometric examination of the patient as far as optimizing the ocular surface? We all know the importance of that when before doing the surgery, but we believe it should be done even for before a biometry. Would you like to talk something about the impact of the ocular surface before doing either a immersion A scan or an optical biometry?
So, ideally, in any setting, it would be best if this is being done on a pristine cornea. So, essentially, when whoever is seeing the patient first, if, for example, if your optometrist is seeing the patient first and they are doing a retinoscopy, they find a dull glow, it's better that they first subject the patient to either an optical biometry, or if you're using an immersion, to an immersion, and especially take the K readings first. Most importantly, the keratometry first. Yeah, and the reason is because once we do any contact procedure, like the applanation or any of the other procedures, or apply dilating drops, it breaks down the ocular surface. You start getting punctate erosions, and the repeatability of these keratometric measures go down. Apart from getting the accurate reading, even before you are seeing the patient or counseling the patient about various options, it's nice to have your IOL power printout. It tells you whether there is a toric requirement or an astigmatism requirement for this patient. And your entire explanation, counseling to the patient changes based on these inputs. So, ideally, get the biometry done on a pristine cornea and get it done immediately after the patient walks into the hospital, and have it ready before you can advise patients.
Excellent. Uh, Thank you so much. I think next we have Dr. Partha Bishwas, who needs no introduction. He's the man behind this entire scientific show, a wonderful scientific extravaganza that he has put up. And Partha is going to be speaking to us about managing posterior capsular rent. He comes with a very wide experience both in cataract surgery and refractive surgery, and it would be good to know his nuances of how he deals with this problem.
Thank you very much, sir, for that very kind introduction. And to tell you the truth, as a member scientific committee, I learned a huge amount from not only Dr. D. Ramamurthy and Dr. Lalit Verma, but all the preceding chairman scientific committees. And I hope you're having a good time today. And any problem, the one point contact for you is me. So any problem anywhere, please let us know. The next thing, of course, I don't know why Ramurthy sir gave me this posterior capsular rent topic. Maybe my experience was highest in this, I don't know. So we'll come to this topic and assess it in that way, in a very practical situation. If a posterior capsular rhexis is possible in a patient who has a PCR, a PC rupture, then things are different. If it is not possible, then things are different. Now let us look into the situation where it is impossible to have a PCC. So this is a situation in which there is a large chunk of nucleus you can see, and we have detected that there is a PCR there, a posterior capsular rupture has occurred. So what we are doing is to compartmentalize this area into two by high molecular viscoelastic. Vitreous has not come in, so the nucleus is set apart, and we can still do a good phacoemulsification, keeping in mind that if little bit of vitreous is there in the anterior chamber, that has to be ascertained first. And that can be done with placing the tricot in the anterior chamber. This was not needed in this case. So more or less we have not had, and therefore we are going ahead and doing also the cortical cleanup in this case. So once the cortical cleanup is done, things are much easier. But we need to know that the microscopic view that our best microscopes offer us may not be the proper guide always for a vitreous that is in the anterior chamber. So we place in the lens, but what is the most important thing here is not only placing in the lens, and we place it in the sulcus here. It's a 3-piece lens, safest if you have any issues, and that means you have to have a 3-piece backup for every case of yours. I'm doing that sweeping part, which is actually not the best thing to be done or to be practiced all the time. What is important for the practice is this: you have to put in triamcinolone in the anterior chamber and see that there is any vitreous at all or not. If there is none, then the job is done. So let's go to the next one. The next video is a video that shows you that everything was going on very well, and it was at this very last time that there was a PC rupture. Now, a PC rupture occurs, as we know, the commonest occurrence time is when the IA is going on, and now we have a small PCR that has occurred, and it's very important to convert it into a nice PCC. So it cannot be always done. What is important is to place high molecular weight viscoelastic in the anterior chamber, not too much, not too less, just enough to get that concavity. And then with the microrhexis forceps, all that you have to do is a nice small capsular rhexis can be carved out, and then this bag is stable. You can put a 3-piece, you can put a single piece, and the job is done. Of course, a bulky 3-piece, like a single piece like this in the Rayner style, can also stand a ruptured bag because it's been converted nicely into a PCC. Now let's look at the next experience that we have. It's a large PCR, and with this large PCR that is there, and there's quite a grade 3, grade 4, grade 3 nucleus there in the anterior chamber. We take it off, and gradually this amount of PCR that there is, it's not possible to convert it into a PCC here. So we are able to take off the most of the part of the nucleus, and as we take off the nucleus part, then what we have is we need to put in the viscoelastic while the phaco needle is in place, and that's an amount so that we are able to remove also the cortical matter. So in most of these cases, the point where vitreous comes into the anterior chamber, that is the point where you have to put triamcinolone, do a vitrectomy, and then go to the next step, which is actually mandatory. Now, placing a 3-piece lens into this, again into the sulcus, and capturing it, because you have a nice capsular rhexis, and the capturing will ensure a good centration. We'll go over to the next video, and here is a video that is actually controversial. Now, a trifocal IOL in a PCR, should you or should you not? This patient had a trifocal IOL in the first eye, and therefore with a PCR, and we could put it in the bag. So we placed it in the bag, and this trifocal IOL in the bag does give the possibility where you can do it when you can put a trifocal IOL even with a PCR. However, if you cannot put it in the bag, it's best to abandon the trifocal and then place sulcus, a 3-piece lens in the sulcus with the amount of counseling that you have to do to the patient. But it's important to remember that these lenses are for long term. You just put it in and you say that everything has gone on well is not the job done, because these patients will have problems of if you place a single piece lens in the sulcus, the problems that we know of, uveitis and rotation and difficulty, all those things will occur post-operatively, and it's best not to be done. So here we'll go over to this next case. Now I'll just go into the last two small clips of videos. There is no PCC. We cannot do a PCC in the next two cases, but can we still put a IOL in the bag? So these are two important cases. They have to be taken as it comes. If you feel that you have the expertise, if you feel that the situation is good, if you feel that there is no vitreous into the anterior chamber. I have 1 minute, I think, no, sir? Okay. So now this is a posterior capsular rupture. You can see it's a transverse rupture of a posterior polar cataract. So what we are doing is we are landing this single piece lens in front of the iris. That's the technique that has to be followed. So the single piece lens goes in front of the iris, and then you have to hook and pivot it with your manipulator and place it directly under good supervision and under good control inside the ruptured posterior capsule, but you have the anterior capsule intact, and you have that part of the posterior capsule which works like a hammock. And also in the trailing haptic, you have to do the same. So it's curving the arm of the haptic, that is important, and it has to be landed in the bag. There should not be vitreous into the anterior chamber. Then only you should go ahead and try this technique. This technique is good, but in very limited cases, and if you think you have the expertise to do it, please go ahead and do it. This is the last of my videos, and this is a little more difficult. It was a longitudinal and eccentric rip that we had. Just 1 minute. So this is a longitudinal rip that we had. The other one was a transverse rip. Here we are placing the high molecular weight viscoelastic in the bag, and then getting across to take off the cortical matter. And once the cortical matter is taken off, you can see that it's again very important that replacing and refurbishing the anterior chamber with more and more viscoelastic as and what is required. And you can see that the longitudinal tear is there. I'm opening up with high molecular weight viscoelastic the space between the anterior capsule and the ruptured posterior capsule. That is again another technique that one has to follow. And again, landing this intraocular lens, single piece intraocular lens in front of the iris. Once it is in position, then I turn it around and then place it. The pupil has to be very widely dilated. We have to see that it is going inside the bag and nowhere else, because if it goes and sinks into the vitreous cavity, it's a mess, and then you have to take it out and remove it, do a vitrectomy, and then put a 3-piece lens. But if one can get it through like this, like what we are showing, you will have a stable bag even though it is ruptured and you have not created a PCC. So these are a few situations that I wanted to share with you. And of course, triamcinolone assisted vitrectomy, if it is required, is very, very important. Thank you very much for your patient hearing.
Excellent videos, Partha. I mean, almost covered all aspects. Dr. Chetial, I want your inputs on this. All the cases which were so efficiently managed, Partha did the anterior vitrectomy through the limbal route only. There was no pars plana incisions. Nowadays, there's a lot of talk about this. I personally also do what Partha does. I have done through pars plana, but more often I find that I've been doing it for 20-25 years, and I find that it works quite efficiently for me to do through the limbal route itself. And of course, as he showed, checking with the triamcinolone acetate. What is your take on this? Are you, any of these complications, are you doing only through the pars plana? You also tend to go through the limbal route?
I think what Dr. Partha showed, followed by 99% of our surgeons. I think that is the way we have been handling these PCR happening on the table most of the time. I also do the same thing. I do anterior route only most cases, because it is important to detect PCR as early as possible. And your management can be much easier if you can pick up early. It is only when things become out of the control, then you are in a difficult situation. Doing a pars plana vitrectomy at that stage can be really challenging for an anterior segment surgeon. The patient is most of the time under topical anesthesia. and chamber is loose. It's not tight, and making the port is also very difficult in these cases. In that process, you might create more damage than doing a simple anterior vitrectomy, because you require very little anterior vitrectomy in these cases. And the use of triamcinolone, which Dr. Patha showed, really gives a good clue that you have done a good vitrectomy in these cases. We don't have to go in a pars plana that will disrupt so many things. Untrained person. I've seen people creating complication because of that only, and I've seen expulsion happening in that case, because the amount of force by the person doing in an open chamber, and the entire thing is coming out, the vitreous whole thing coming out, and even a retina is coming out in one case. So unless you are expert in that, don't try that. Try a simple anterior vitrectomy through anterior route, and you can manage very nicely. You have 2 side posts, do from 2 side posts, change your hands, and you can effectively do vitrectomy there.
Good. You have any comments, Suresh?
Just had a quick question, sir. For the triamcinolone acetate, when we are putting it, do you dilute it or do not dilute it?
Yes, I usually dilute it, and the diluted one, in the earlier days, I would not dilute it, and it does not actually create the problems that we actually read in the papers and the textbooks. So the IOP going up and things like that. But what also, as of now, I'm diluting all of them, but it definitely gives a very good post-operative result. The cornea is very pristine nearly the next day. So despite having trouble, the patient is seeing quite well.
No, the reason I ask, sir, is that the retina surgeons say that the vitreous stains better when we don't dilute it. When we dilute it, it may not stain very well. And I also noticed in one of your cases where you have already implanted the IOL, and then you're putting the triamcinolone to look for any residual strands.
Yes.
In those cases, it's very unlikely that the triamcinolone will seep into the vitreous because the IOL is already there. So would you recommend just not diluting in those cases to visualize better?
Basically, it is a good wash of the triamcinolone also is important, and the triamcinolone should not go into the vitreous cavity, which is important.
Right.
Thank you.
Excellent. I think you brought out 2 very important points. There's so much of talk and by excellent surgeons with good videos saying that the pars plana vitrectomy is the way to go. As Dr. Tityal said and Dr. Partha showed, if you are comfortable going through the anterior route using triamcinolone acetate and doing an adequate vitrectomy, quite often takes care of the case. And I'm sure that's what most of us are doing. Another very important point was that whenever the nucleus goes in, he did not even show any video of that. Once the nucleus drops, once it goes beyond the anterior chamber, then I think we are not going to be discussing this because we are essentially anterior segment surgeons sitting here. Once it goes in there, then you just do an adequate wound toilet, anterior vitrectomy, remove whatever cortex is easily possible, then call up a vitreoretinal surgeon to handle the case. If you are in an institutional setup, it can be done on the same day, or even if the patient goes back in a pseudophakic or an aphakic state, 2-3 days later, it can be taken care of quite adequately. Thank you so much, Partha.
Just one point I like to highlight, because all these cases where you have PCR and you have done vitrectomy, the post-op management is very, very critical in these cases. You must do a peripheral screening within the first few days, and keep seeing these patients every month, and make sure if the patient understand what is floater and flashes, because these patients can have these symptoms anytime in the future. Immediately they should report so that you can manage those difficult cases. They may have a small tear, small hole, traction can be managed, and OCT is must in these cases in the regular follow-ups.
Thank you for that important input. Now we go on to Dr. Chitra, who's going to be talking about addressing residual refractive error post-operatively. Suresh did speak about accuracy of biometry. We always strive for the best. But even in the best of hands, best of institutions, there are refractive surprises. And today, with the patients expecting near emmetropic outcome in all situations, let's see how she handles it.
Very good morning to one and all of you, and my special thanks to Dr. Ramurthy for including me in his course. And my due is to talk on residual refractive error post-operatively. A residual refractive error post-operatively is actually the primary reason for dissatisfaction after a premium lens surgery, where you have counseled your patient for long and told him that you're going to give him visual independence. And the sources of these residual refractive errors in this particular study, which was done in Wales from 2003 to 2010, long back, in that huge number of eyes, only 164 of these eyes had issues. And these were the 4 main reasons which was outlined and which is relevant to us, is the inaccurate biometry, wrong IOL power selection, transcription errors, and handwriting misinterpretation. And then you realize that so much of it is in your hands and need to be preoperatively conscious cannot be undermined at all. So planning for the worst is how you are doing the best before the surgery. Now, having said that, we do have a range of intraocular lens formula, the 3rd generation, now the 4th generation, the 5th generation, which, so it seemed necessary for you to know how accurate you are with these. So all of these, for many of these formulas were put together, and we looked at the target emmetropic outcome within -0.25, ±25, or ±0.5, and it was checked with those on optical biometry, like it could be a spectral domain or a swept source OCT or an OLCR. And what came out of it was the best as of now are the Hill RBF, the Barrett Universal 2, and the EVO, which is the emmetropia verifying opticals. But even then, they were only 92% within ±0.5 diopter of target emmetropia. So the formulas themselves have a limitation there, but if you add it with your inaccuracies, then that is going to get compounded. So what you need to know is, you would hear everywhere about different formulas by different surgeons. You should go back and use the formula which is best suited to you. For that, you need to analyze your results. You might find that you could want to use an Hill RBF and an Barrett Universal 2 and keep them as 2 formulas to go on. But believe me, the Hill RBF is based on a statistical model, and Barrett Universal 2 is on a thick lens formula. In spite of being different technologies, they do work very well, and these are absolute good platforms to compare, because it's often necessary to validate your results with 2 different IOL power calculations and also check for consistency. You need to also remember, when you're doing premium IOLs, your threshold for using a toric IOL has to be extremely low. This was a phaco study which was done. What they found was that out of 100% person getting operated, 70% of them were fine with even the 3rd generation formula. It is that 30% of them, when you do the keratometry and you find that the standard deviation is more than 0.2, then you need to get cautious. Is it dry eye status? You check for dry eye. If there is dry eye, treat the dry eye and then repeat the biometry. In some, you get to know it's a refractive surgery eye or a keratoconus or PMD. Then just a routine topography is not enough. You have to do a tomography. You may have to look at the EKR value. You may have to use those specific formulas. You may have to use the right toric calculator. And most importantly, you have to use the 4th generation formula and beyond. Of course, it goes without saying, it has to be a perfect surgery, right from getting that right rexus overlap over the optic of the IOL and ensuring that you definitely check your post-op outcomes to understand where you are. Are you poised for a premium cataract surgery without any of these residual effects? Then comes determining what went wrong. Now, this was a patient who came 1 week post-op surgery, and if you look at it, he had a +8 diopter of refractive surprise. Now, before we just go in and straight remove the lens, you need to look at the pre-op scan and the post-op scan to understand. You need to look at the labeling on the IOL. You need to look at your EMR entry, whether there was any, where was the error. And you found that there was actually no error at all before you assume it is the IOL part which is wrong. You have to do a refraction, repeat the refraction with another optometrist. You should do a fundus evaluation, whether there's a CME lurking, is it the right time to explant this lens? You need to look at the surgical records, and then if everything tells you it's a wrong IOL, then you would remove it. But now there are certain considerations. You need to be sure it's a stable refraction. It's a post-RKI. You may have to wait for the refractive stability to occur before you jump. Of course, +8 is too much. You would remove it. But for small errors of +1.5, 2 and all that, and this is a post-RKI, you have to wait for the stability of refraction. You have to look at the age of the patient. Is he fit for surgery? Not this +8, but another smaller residual error. Does he need a surgery? Are his visual needs met? With sometimes having with the rule as astigmatism will allow him a depth of focus and better reading ability. Sometimes if both eyes are operated in a binocular status, he might do well. Then do I remove the lens? It's something you have to keep thinking in your mind, because there are challenges when you're going to remove the lens unless you are a veteran surgeon. So you have to, at that time, there is more dry eye, there's going to be more inflammation, take care of that. Look at the zonular status. You have to be extra cautious. It's an already operated eye. Is there already a YAG opening there, or a PCR is there? So, all of this you have to look at before you decide to remove the lens. And when you're going to do your refractive enhancement, could also be like if there is a little residual error in a multifocal, sometimes if you operate on the other eye and give time for neural adaptation, the patients do well. Again, if it's a toric IOL, it is better that you go and realign the toric IOL within 2 weeks or at least, because then there'll be capsular fibrosis, and then moving the lens would impose more stress on the zonular apparatus. Of course, if it is a wrong IOL, you need to remove it earliest. Sometimes there'll be just a small amount of refractive error which is there. Just doing an arcuate keratotomy is all that is needed. Sometimes you will find that the patient is just not happy, wants some more. Then you could use your microkeratome if you have. Don't charge them for it. Then do an enhancement, or use your do a PRK and then treat them. But then you should look at the corneal thickness in these patients. The older patients would have dry eye status that has to be treated. They can wait, but you have to wait for the refractive stability, the topography to be all right before you decide to do enhancement. Now look at this particular file. If you look at the sphere and the cylinder, the spherical equivalent is nearly 0. Just looking at this thing itself, you know that this patient will benefit by toric IOL rotation. But you have now the astigmaticfix.com or the Barrett TK Barrett treatment formula, wherein it will tell you when to rotate the lens. If you enter your data in that, it can go on the website and do it too. It will tell you when to rotate it, when you have to do a bioptics or a laser touch-up. It will tell you when to place a piggyback lens. It will tell you when you have to do an IOL exchange. And in this particular patient, we had to just do a repositioning of the toric IOL. You don't have to inject viscoelastic in these patients. Just open up the side ports. You may have to make a fresh entry in that area, and just with the irrigation on, you could realign it. And if you're lucky to have an ovarion imaging or something, it becomes easier. But otherwise, preoperatively, you could mark on the slit lamp, and whichever way you do it, and then go back and realign it. And these patients do so well. And that kind of visual independence you give, he is going to bring you 10 more patients. Again, but this was a particular case wherein, this is the particular case which I'm coming back to, wherein the IOL had to be removed. So you need to get the haptic and the optic out of the bag, pull out the haptic, one of the haptics, and hold it, and that gives stability. And you need not have to cut all the way up. You need to have injected viscoelastic, keep the PC away. Even that much of a cut is enough. And with the hand-over-hand technique, you could remove it and replace it with the other lens. This patient came back after 4 months post-op and had a significant hyperopic error. So you can do a piggyback lens in these eyes, and how essentially it could be a lens material, preferably a hydrophilic, which is not the same material as the primary lens. It should have a larger optic. We have Sulcoflex lens and the other similar companies, and the haptics allows it to rest in the sulcus properly, and it has a posterior concave surface. So there is a space between the primary IOL in the bag and this, so there won't be interlenticular opacification, and the haptics of the second IOL should be placed at right angles to where it was in the primary case. Then, of course, post-operatively, you can see that the vault is fine. The second eye often gives you a chance. As you can see, that the patient had a symphony implanted in multifocal, and the patient had a +1 residual error, and he was just not happy. But he was an avid reader, and that Technis multifocal were available, which has a +4 add, and after implanting it in the second eye, he did very well. This was another patient who had a symphony done in the other eye. He had a small amount of plus bar and was not that happy. So you can do a micro monovision correction, give him a more myopia in the other eye. But let's understand, the difference of myopia between the two eyes should not be more than 0.75, because then there'll be loss of stereopsis and quality of vision therein. So within that range, you could do a micro monovision and you could take care of these patients. But there are some patients who have a little near vision difficulty, but they look happy. Just because you have theoretically fixed about 6/6 N6 vision, if he's a happy patient, just let him be, just pat him on the back. But you just know that how you need to to get careful in your future cases. Probably the actual treatment of residual refractive error would come when there's a breakthrough technology where we have post-operatively, like the light adjustable lenses, we could adjust the power of the lenses if something like that comes, or we are better able to estimate the effective lens position, which is what is a challenge with all the IOL formulas. If we have done it all, then probably some years down the line, we will all be talking of doing only 6, 6, and 6 for all our cataract patients. Thank you very much.
That was a very comprehensive coverage, Chitra. I mean, in case you have to do IOL exchange, how much time would you allow before you take it up?
If you are so sure, as I told you earlier, that an IOL exchange is needed, that's obvious, then let's not waste time on that at all. But you have to be sure. So because before fibrosis and the haptics get attached, that you have to cut the haptics, just remove the haptics, let's not go that far. You make it the easiest time for you yourself to remove the IOL out of the eye. There are different ways. You can pull out the haptics, cut it halfway, or you can cut it full way. There are some hydrophilic lenses where I've seen surgeons doing it without cutting it at all, hand over hand technique. So there are some people just cut one triangle.
The point I actually wanted to make was, most often we are implanting hydrophobic acrylic intraocular lenses. So obviously, if you get a +6 diopter surprise on the first post-operative day, you'll go ahead and explant the lens on the first day itself. But otherwise, if it's a smaller error, it's a good idea to wait up to a period of 1 month. And if you feel that this lens has to be exchanged, it's a good idea to do it before a month's time. It's possible to explant these lenses, take it out of the capsular bag, even at 6 months, 1 year, we have done that. But before the capsule really fibroses down and holds this lens, it may be a good idea to take this lens out. Thank you so much. Thank you. And now we have none other than Professor J.S. Thityal. We all know he's an excellent academician, excellent surgeon. Now he's taking the Apex institution with his academic capabilities also. And he's going to be talking to us about optimizing ocular surface perioperatively. Being a superb cornea surgeon, as well as a cataract surgeon and a refractive surgeon, I can't think of anyone else who can cover this topic more optimally. Over to you, Professor.
Thank you, Dr. Ramamurthy, sir, and good morning, friends. You heard so many talks on today's session. One thing which is, real, you can say, bother as far as the patient is concerned and the surgeon is concerned is the symptoms of patient. And you all do cataract surgery and you have done a perfect surgery and patient not happy. And that is a scenario so difficult to make him understand what is wrong in his eye and what should be done, why he's having that problem of watering and itching and irritation and foreign body sensation. I think these are 3 or 4 words which really, kills your morning when patient comes back to you. 6/6 vision and he's not happy. So there is importance of this particular talk where we need to look into ocular surface of all our patients who are coming for cataract surgery, and it has a very, very significant importance in managing cases of cataract surgery patient coming. We know that large number of patients may be suffering from a dry eye disease or some sort of ocular surface disorder, and they are asymptomatic. And we all understand we have to follow a routine where you pick up these patients as such. If you look into recommendation from American Academy Preferred Practice, ACRS, they'll say always look for a ocular surface disease in your patient before cataract surgery. That is what we also do. Every patient of cataract surgery, I ask my resident to put 1 drop of fluorescein and see what happens to ocular surface, and that will decrease the problems. If you see here, almost hardly few patients will come pre-op having some sort of symptoms. Only 1/5 of patients have a symptoms of dry eye when you actually ask them. But if you examine these patients, almost 60 to 80% patients will have a dry eye features. So that is a very significant point because that has an impact onto your outcome in your patients. This unhealthy ocular surface or unhealthy tear film has so much of importance to look into. It can give you, as Dr. Chitra was talking about, inaccurate keratometry. Your entire IOL power calculation may not be appropriate for that particular patient, especially if they are coming for a multifocal or a trifocal lenses, and they'll have a suboptimal visual outcome subsequently. And there will be a need for enhancement, which Dr. Chitra is talking about. Subsequently, you realize you have done a mistake in these patients. Most importantly, the poor quality of vision and patient unhappiness is because of ocular surface most of the time. Patient coming back to you with the halos, a poor vision, we think of posterior capsule first. We never think of ocular surface. So there's the importance of seeing, examining, and investigating your patient ocular surface, especially for a premium IOS. Other important thing is after surgery, the dryness or ocular surface is going to deteriorate, and patient will be very, very unhappy in these patients. So we need to look into incisions, the toxicity which can happen on the table, look for inflammation which may be contributing the increase in the dry eye features in the patient, look for a meibomian gland dysfunction, and if needed, change your post-op medication to improve these patients. Therefore, we need to identify patients with dry eyes or a high-risk patients, treat these patients before surgery. Surgery in cataract nowadays, almost 90% of cases are elective surgery. So you can wait, you can treat the patient and plan subsequently. A patient who may not be fit for a multifocal lens, after treatment, he may be, yes, you can still give him the opportunity of a trifocal lens in these cases. Intraoperatively, make sure you don't damage the ocular surface. And post-op, most importantly, use steroid cautiously. And if you are using anti-inflammatory medications, that should be preservative free. Some patients require a glaucoma medication. Always now we see a lot of glaucoma medication are preservative free. That is a very important aspect. In pre-op, I think history taking is very, very important for our patients. We don't ask them, in fact, and they come with the watering and itching and irritation a post-op period. One question you should always ask your patient: do you have watering, pain, redness, irritation often on your case? Are you putting any artificial tears? Because that's going to guide you if patient would have a ocular surface disease. Especially patient with anti-glaucoma medication, you should be very, very careful. Or patient who has a diabetes or undergone laser treatment, this is very, very important thing to look into. And more importantly, these are old patients. They may be having arthritis, systemic disorder, disease, which should be also noted and recorded in these patients. Investigations, you all know, we are looking for ocular surface. So TBUT and staining is very important for your patient. Look for a surmas which may not be very accurate, but sometimes a patient are poor surmas, that is a indicated patients are dry in these patients. Tear osmolality may not be available to most of us, but it can be done. Mammography nowadays can be done very effectively. Look for a meniscus, because that gives you a lot of information, the height, the debris, all these things are important. See, this is one important investigation. Sometimes your optometrist or a person who is doing investigation tell you that patient doesn't have a good ocular surface by just looking into keratometric Myers, or if you look into a telecentric Myers in your IOL master, he can tell you that this patient has an ocular surface disease. If you see this particular case, looks quite normal. You put a fluorescein, see how many surface, punctate staining patient has. Sometimes you have a conjunctival calluses, which may be the cause for a poor patient's outcome in these cases. Examine conjunctiva also very appropriately. See this inflammatory mark in these cases. MGD is another important area which should be looked into. If you have gadgets, you can look into tear film, lipid layer thickness, and the meibomian gland. That is very important. You can treat them. So what should be goal for our patients? We can treat them in a manner which decreases the aberration and improves the functional visual outcome, and that is going to decrease the symptoms of patient in these cases. So these are various treatment modality we have. Artificial tear is a mainstay of management for all dry eye patients. Holds true for cataract patients also. We can, especially patient with an inflammatory dry eye, we can use steroids, or we can use cyclosporine in these patients. Punctal occlusion is not desirable as such. Unless the patient has surmas which is less than 5, and your patient is going to have severe punctate stainings, you might think of this along with the anti-inflammatory in these cases. And after surgery, if patient improves, you may have to remove. So always go for a, which can be, temporary punctal plug should be done in these patients. Blepharitis, lid margin examinations are very, very important in these cases. And this is the various ways you can treat your patient as such. Intraoperatively, you know that if you do incision appropriately and place the viscoelastic over the cornea, you're going to damage less epithelium. Never use topical medication excessively in these cases of dry eye patient. That is going to actually create the problem in these patients. Size-wise, this is one controversial statement. SICS patients have more dry eyes than phacoemulsification, which I don't feel correct, but this has been reported in the literature as such. So dry eye as such after surgery may enhance within the first 1 month or 3 months, and slowly within 6 months dry eye settles down to most patients with treatment. But there are certain percent of cases dry eye never settles down. So this is one of my patient day one after beautiful cataract surgery. You can see a thinning happening in the area where you have a conjunctival bogginess. So this is called Dellen. And if you see the stain, there's a pooling here. In such cases, ocular surface management is very appropriately. If you don't manage that, there'll be a melting and you may have a perforation also. So lubrications, if needed, contact lens, soft contact lens, a few days should be put. If there's a thickening of a conjunctiva, pterygium should be tackled appropriately also. This is one case example of one of my patients where I put multifocal IOLs. Patients are not happy with 6.6 and N8 vision, poor very quality. Now this is what staining showed, a lot of punctate staining, and the wavefront aberration was huge in this patient. So we treated this patient as we described the artificial tears, especially sodium hyaluronate as one of the important combination there. Nighttime gel and cyclosporin for 3 months. Now after 3 months, patient improved significantly. So this is a significant that any patient who has symptoms, make sure you stain the cornea, stain the ocular surface, rule out dry eye in these cases. To summarize, all cataract patients can undergo dryness. Before surgery, they may have, almost 60% of cases have a dry ocular surface. And after surgery, they also increase and create a lot of problem for us. The counseling can also be very important aspect for these patients. If possible, use preservative-free medications. Unfortunately, steroids don't come in a preservative form, but it should be available very, very soon. And counseling will be very important for these patients. Thank you for your kind listening. Now we have Dr. Ramamurthy himself.
Thank you, Professor Tityal, for this very comprehensive coverage. One question to you. We have multiple lubricant options available to us: carboxymethyl cellulose, polyvinyl alcohol, sodium hyaluronate. Do you routinely put all your cataract patients on lubricants, even though they don't seem to have any problems? And do you have a step ladder pattern by which you increase the type of drops that you put?
I have a certain, as I talked about, there are few patients who have a dry eye beforehand also. There we add lubricants before surgery and continue lubricants for at least 3 to 6 months these patients and titrate them. In a post-op period, I normally don't start lubricants in the first few weeks because that time you have so many drops going on. But if patient has a symptom of irritation, especially the incisional related incision, I add lubricant for these patients. A patient who have a staining coming up, there I add the nighttime gel in these cases because steroid is going on at that period. So gel combination only I add if you have the features on the ocular surface. Otherwise, simple lubricant drops at least 3 to 4 times a day is compulsory for all patients.
Thank you. Thank you so much. And Dr. Abhay is not attending the conference. So basically, I'm going to be combining two talks. I hope to give you a very comprehensive coverage on astigmatic control in cataract surgery in the next few minutes. All of us know that almost in the anterior corneal curvature is what matters. Nearly 20% of our patients have more than 1.5 diopters of cylinder. About 10% have more than 2 diopters of cylinder, and rarely even 3 diopters of cylinder can be there. And because for the patients to have good quality and quantity of vision is extremely important that we address this cylinder during our cataract surgery. So even a 0.5 diopter of uncorrected cylinder, when the pupils is about 4.5 millimeters, which is often the ambient pupil, can cause this amount of deterioration in the quality of vision. And that's the reason that you need to address this quite adequately. And what are the options available to us? Obviously, the mainstay is toric intraocular lenses. You also have laser arcuate keratotomy, limbal relaxing incisions, opposite clear corneal incisions. I'll just briefly go through these things. Um, for a long time, I used to think that my 2.4 millimeter clear corneal incision causes a 0.44 diopters of astigmatism. I used to position the incision depending upon the axis of the astigmatism on the steep axis. And today, it's well proven that the surgically induced astigmatism, when you look at the centroid value, because the astigmatism not only has a magnitude but also has a direction which tend to cancel out each other, is more in the range of about just 0.1 diopter. We'll be alluding to this again later, but suffice it to say, no longer the concept of positioning the astigmatism on the steep axis is valid, because it seems to have hardly any effect. The only place where I use it occasionally is that when I'm doing a phakic intraocular lens, those younger patients have a with the rule astigmatism. I create a 3 millimeter incision, and a superior incision has a greater impact on astigmatic neutralization than a temporal incision. In those cases, for a 0.5 diopters or so, I might use it. But as far as cataract surgery is concerned, it's always temporal clear corneal incision and dealing with the astigmatism by other means. And this opposite clear corneal incision, it's a very old video of mine. At the end of surgery, all you do is to pass in a 2.4 millimeter diamond knife or whatever knife you're using in the nasally, and you expect this to act. There are some papers which says that it neutralizes up to about 0.2, 0.3 diopters. Especially no instrument is passing through this incision. There's no distortion. This wound almost completely heals up. And again, I believe that this is more for the surgeon's comfort level, believing that he is doing something for the patient rather than any true impact as far as serious astigmatism is concerned. So this is again something that I hardly practice in my situation. One of the limbal relaxing incisions is something which is very relevant, and this is the way it's done. But the problem with that is that it is something like radial keratotomy. You do not know how much is going to function, on whom it is going to function, and whatever impact you get initially, how long it's going to last as far as the patient is concerned. So basically, in case you have a patient who is going in a multifocal intraocular lens with a 0.5, 0.75 diopters of astigmatism, with a guarded diamond knife of about 600 microns, you can go ahead and do a limbal relaxing incision. But this is again, the amount of impact depends upon the corneal hysteresis of that patient, not just the size of the incision that you are creating. And that's the reason you cannot be very sure about the impact of these incisions again. I had given up doing limbal relaxing incisions almost for a decade, but once I had got hold of a digital imaging system, for the last 10 years or so, once again I started doing limbal relaxing incisions, for the simple reason that here there is more accuracy. The exact arc length of the incision that you need to create, the position of the incision is better determined, but still this is for small amounts of astigmatism where you can do a good cataract surgery and the end of it doing a limbal relaxing incision. This is just the scars of a first day post-operative limbal relaxing incision that has been done. Once the laser platform became available to us, the laser arcuates has definitely a role to play, and that's these two incisions are what you're seeing after the nucleus emulsification, after the rexus. These are the incisions which are created. Even if it's against the rule astigmatism, I'm doing a clear corneal temporal incision, I go ahead and place these incisions because they are placed at 8 millimeters. My incision enters the cornea before that, and as you can see that you have to always open up these incisions. There was a talk about intrastomal incisions because it causes less amount of irritation, but unless you open up these incisions, they are not effective. Here again, as you can see, I put in a multifocal intraocular lens. This patient had about 0.6 diopters of astigmatism. A toric intraocular lens was not indicated. So I go ahead and use the laser arcuate keratotomy. Maybe this is slightly better than doing the earlier limbal relaxing incision, because these incisions are image guided, they are more precise and uniform. The depth of these incisions can be precisely controlled to 80% or 90%. There's good visualization of these incisions, and it's also claimed that these are titratable in the sense that you do not open them on the first post-operative day. Wait for about a week's time, and depending upon the residual astigmatism, you can open up this. I have really not done this even once, and you can see this pad laser arcuate keratotomies that have been done. Suffice it to say, here again, you can use it for cases where there is small amounts of astigmatism, where the toric intraocular lens is really not indicated, and you can use these incisions to titrate the residual astigmatism that the patient has to deal with in the postoperative period. As to my mind, the mainstay for treatment of astigmatism in cataract surgery is the toric intraocular lenses. Let's dwell upon this a little more. Ideally, a toric intraocular lens is to be placed where the astigmatism is orthogonal, that is, where the steep and the flat axis, even if they are oblique, are exactly at 90 degrees to each other. Whenever the astigmatism irregular, like in corneal scar, post-radial keratotomy, in a case of keratoconus, these are relatively contraindicated. But having said that, there are quite a few cases of keratoconus where we do a topo-guided PRK or corneal intacs. They center these rings, and then the residual astigmatism we go ahead and use, if it's a cataract surgery, using a toric intraocular lenses or a toric ICL in case it's a younger patient. Here again, it's not refractive accuracy you promise, but most importantly for the purpose of today's discussion, it's orthogonal astigmatism where the steep and flat axis are at 90 degrees to each other. It's a regular astigmatism where this functions the best. One of the most basic tenets, I think all of you know, is that refractive astigmatism rarely has a role to play, because what we are dealing with in the postoperative period is the anterior corneal astigmatism. You can see you do not really need an eye trace to go ahead and implant these toric intraocular lenses, but just to drive home the point, this is from the cornea, this is the internal from the lens astigmatism. And as you can see in this particular case, almost the entire corneal astigmatism that the patient was having in his glasses, about 1.5 diopters, is from the lens. The cornea itself is quite pristine with no astigmatism, and obviously this patient, even though was wearing astigmatic glasses right through his life, is not a candidate for a toric intraocular lens. On the other hand, you can have a situation like this where the corneal and the internal astigmatism tend to almost neutralize each other, and the patient has not been wearing any toric intraocular lens. But then because once the intraocular lens is taken away, this corneal astigmatism is going to become manifest. So this would be a candidate for a toric intraocular lens. So just you definitely should have a look at the astigmatism in this patient's spectacles, but you should not be guided by that. It's essentially the corneal topography or the measurement with the of the corneal astigmatism which should guide you. I would say that the last 6 or 7 years, our results with toric intraocular lenses have improved dramatically. And that's not just because of better lenses have become available, because our concepts about these three basic features have significantly improved. Let me dwell upon this for a little briefly. Posterior cornea was always an enigma. Our machines don't measure it. We do not understand it till Doc Cock, Graham Barrett, etc. came out with their papers, seminal suggestions that the posterior cornea has a significant role to play. It is most often steeper vertically with a mean power of about 0.3 diopters. So whenever you have anterior against the rule astigmatism, this is potentiated by the posterior corneal astigmatism. But if you have a with the rule astigmatism, which is quite rare in the cataract age group, the posterior corneal astigmatism tends to reduce this. So this is hence the importance of taking into consideration the posterior corneal astigmatism apart from just the anterior corneal astigmatism. And when you take both these into the consideration, that's when the concept of total corneal astigmatism comes in. Another very important aspect that you need to understand is that the astigmatism on the anterior cornea of the patient is not just stable right through the lifetime of the patient. The posterior corneal astigmatism does not change, but the anterior corneal astigmatism changes by about 3/8 of a diopter for every decade of the lifetime of the patient. That is exactly the reason why most of our laser refractive correction patients who are of the younger age group have with the rule astigmatism, while most of our cataract age group patients have against the rule astigmatism. And this is again something that we need to remember. The implication of this is that when you have a younger patient with the rule astigmatism, undercorrected. So in a pediatric cataract, if you're thinking of cataract, doing a toric intraocular lens, if it is say 1.5 diopters with the rule astigmatism, also you would not consider toric intraocular lens, simply because this is going to go away on its own during the lifetime of the patient. The other important aspect that we need to understand is that it has been classically explained you need 1.5 diopters of astigmatism in the intraocular lens plane to correct about 1 diopter at the corneal plane. But just like the ELP is important as far as our spherical correction is concerned, it is also the correction of the astigmatism is also dependent upon the length of the eyeball, the overall basic power of the intraocular lens that you're implanting. In a highly hyperopic short eye, you just required 1.2 diopters in the intraocular lens to correct 1 diopter. While in a highly myopic eye, you might require as much as 1.75 diopters. This chart nicely brings this out, where you see that a short eye with a flat cornea just requires about 1.29 diopters, while a long eye with a steep cornea requires almost 1.86 diopters. So there is a toricity ratio where you have to understand. Mind you need not really break your head about this, because most of these things are incorporated in the calculator itself, as you will see. But it is important that you understand these concepts. So whether it's a basic lens, a spherical lens is a +5 diopter, as a +30 diopter, the amount of cylindrical correction that is needed in these lenses are going to be very. We already alluded to this, and today we know that the surgically induced astigmatism has both a magnitude and a direction. And if you look at a plot like this, then they tend to neutralize over the surface, and average centroid value of say at 2.4 millimeter or a sub 2.4 millimeter is just about 0.1 diopter. Or you can just completely ignore this, and irrespective of where exactly of the steepness of the cornea, we go ahead and do a temporal clear corneal lens in these situations. We already alluded to the choice of formula, and the Barrett suite of formula is what we use in our practice. It is not the Barrett universal 2 formula, which is our go-to formula, but is a Barrett toric calculator, which we use for most of our patients. And this is available in many of our optical biometers, also in the AACRS, APACRS websites. Oops, I'm sorry about that. Yeah. This is the drop-down menu you can see in the ACRS, APACRS websites. So even if you're using a immersion A scan and a manual keratometer, you can use this formula and get the benefits out of this. Only thing is, instead of using an optical A constant, you have to use an acoustic A constant in case the particular lens that you're using has the two different constants. All the earlier points that I alluded to are incorporated in this. As you can see, we have an axial length, we have an anterior chamber depth, the basic intraocular lens spherical power is also taken into consideration because of the concept of toricity ratio. Whether it was a +20 diopter or whether it's a 10 diopter lens, the amount of toricity that's required is going to change. You can see the surgically induced astigmatism has been fed in as 0.1. And then the K value, the K index can also change depending upon the particular instrument that you're using. And most often it's 1.3375, but it also can be 1.33 with certain 333. And that again, putting in the correct value enhances the quality of outcomes as far as these calculations are concerned. The reason we go for a Barrett toric calculator as our primary source for calculation, not just for a toric intraocular lenses, but all intraocular lenses, is that it automatically incorporates posterior corneal astigmatism, even if you're not measuring it directly. It takes into consideration the drift in the astigmatism that takes place during the life of the patient, targets about 0.25 to 0.5 diopters of with the rule astigmatism, takes into consideration the axial length and the intraocular lens spherical power, that is the toricity ratio. The centroid value of the induced astigmatism, that's a value of 0.1, is something that you can feed into the your calculation. And the K index is again that can be taken into consideration. Coming to the marking, the very fact that so many different ways of marking is available to us essentially shows that none of them are absolutely accurate. But whatever you are comfortable with, you must stick to standardize it and go ahead and use it. To my mind, if you do not have a digital marking system, marking on the slit lamp with the pupils not dilated, making it a horizontal slit, and using a 26 gauge needle to create a small subcontinental hemorrhage on either side tells you where exactly the 180 degrees axis is there. But if you, of course, have a digital overlay system, that would be the way to go. Let's very quickly look at a couple of videos, and where essentially it's a toric implant. This is, I'm not using a digital overlay system, and that's the Mendel's ring where the orientation of the intraocular lens is essentially shown. And as you can see, I'm making a 2.4 millimeter. Here it's a 2.2 millimeters, a fairly old video, but now I shifted over to a 2.4 millimeter incision, and the toric intraocular lens is going under viscoelastic. And it's extremely important that at the end of the surgery, this viscoelastic is completely evacuated. You usually rotate the lens and position it in such a way that you need about 5 to 10 degrees of rotation for final orientation of these lenses. This is essentially the marks along which the lens has to be oriented. As you can see, I'm going even behind the intraocular lens and evacuating the viscoelastic quite completely. Then I'm going to be positioning the lens. Tapping the lens onto the posterior capsule is also important. Mind you, most of the rotation of these toric intraocular lenses occur in the first 1 hour. That's one of the reasons I patch all my toric intraocular lenses, even though I do most of my surgeries under topical anesthesia for a period of a couple of hours before I see them post-operatively and discharge them and I take off the patch. When you have a digital overlay, either a Callisto or a Varion like this, then the preoperative marking is not necessary, and it's not just the toric markings alone. The capsule, the exact position of the incisions, of course, it's as I said, it's now it's temporal 180 degrees, and you can my side port incisions about 50 to 60 degrees apart, and you are going to be making a main incision of about 2.4 millimeters and subsequently doing a capsular rhexis. And then we go on to, that's at the end of the phacoemulsification. I don't routinely polish remove the anterior capsule. That's the intraocular lens that's being injected. And that now the digital overlay will come on, which automatically takes into consideration the cyclotorsion that's inherent in this particular eye, and also the pupil centroid shift, so that you can exactly position the intraocular lens where it's needed. Removal of the viscoelastic quite completely before closing up the surgery is extremely important. Today, I've almost completely shifted over to a hydro implantation, where you can see there is no viscoelastic that's going in. You would not see the digital overlay here because of some camera compatibility issues, but the Varion overlay is there. And this is, you can see the irrigation cannula in place, which stabilizes the eyeball also. And after the injecting the intraocular lens inside, I just position the toric lens based upon my Varion overlay, and the necessity to remove the viscoelastic quite completely is done away with, which saves about a couple of minutes as far as the surgery is concerned. Oh yes, the you can see the Varion overlay over here, and you can see the very accurate orientation. I think not just for the spherical intraocular lenses, even for toric intraocular lenses, your multifocals, you can consider hydroimplantation. It seems to be a good way to go. We already talked about this digital overlay, and importance of correcting astigmatism. Whenever you're using a multifocal, I did put a trifocal implant. The patient were very happy as far as near vision was concerned. You see that for the distant vision, the patient has a significant residual mixed astigmatism, and the uncorrected vision was just about 618. Patient was not happy at all with the outcome. So essentially, we were to do a laser touch-up, but the patient was understanding. So for the same patient, we had just about 0.86 diopters in the other eye. You can see when I use the Alcon toric calculator, it shows up a T3 multifocal that's necessary, and a T3 panoptics lens was implanted, and it immediately shows that once astigmatism is taken care of, you get a 6/6 N6 vision with a more happy patient. We had to deal with the residual astigmatism in the first eye, which had a monofocal, which had a non-toric multifocal intraocular lens with a laser vision correction 3 months down the line. Again, as was mentioned, whether it's against the rule astigmatism or with the rule astigmatism is extremely important. I'm often asked, what exactly is the cylinder value beyond which you consider a toric intraocular lens? It is not just the magnitude of the astigmatism alone which is important, but the axis is also extremely important. You have a 0.98 diopters of against the rule astigmatism, and what the calculator shows up is a need for a T4 intraocular lens. But on the other hand, if you have almost a with the rule astigmatism, 0.75 diopters of astigmatism, what it shows up is a non-toric intraocular lens is what is needed. That's the reason that we essentially use Barrett toric calculator as your go-to formula, even before the Barrett Universal 2, because when you're using the Barrett Universal 2, we go ahead and recommend these patients, talk to them about a monofocal intraocular lens, then find out that the patient actually needs a toric lens, and we have to start talking to them about a toric multifocal or a toric monofocal. So even before counseling, we go ahead and use this. So my final tips to maximize outcomes with these toric intraocular lenses are multiple measurements of K readings is extremely important. Of course, if you have access to optical biometer, that would be the way to go. Just in case you have to choose between upgrading your mid-level phaco instrumentation to a higher-end phaco instrumentation or getting an optical biometer, I'd always say going ahead and investing in an optical biometer would be the right way to go. But at the same time, it's not that you need an optical biometer to go ahead and start using toric intraocular lenses or multifocal intraocular lenses. We have several centers where we do not have access to an optical biometer, but still we go ahead and use do implant torics and multifocals. Consider, but be not guided by refractive cylinder. Check the ocular surface. Dr. Titial just gave a wonderful talk about the importance of optimizing the ocular surface, not just before the surgery, but even before your measurements. SIA is 0.1 for a temporal to 2.4 millimeter incision. Undercorrect with the rule, overcorrect against the rule. And as far as the surgical steps are concerned, make a little longer incision because you want a very stable chamber. Avoid overinflating these lenses because if you have even fluid behind the intraocular lens, there's a greater tendency to rotate. Do a hydroimplantation or do a complete visco removal and nudge the intraocular lens onto the PC at the end of the surgery so that it rests there. Slightly smaller rexes. Ensure position once the speculum is off. And these are the formula that you could use if there is a residual toricity. It's basically waiting for Maipal to join in. And I think our time is...
Thank you, Dr. Ramamurthy, for a wonderful masterclass on toric IOL implantation. Beautifully covered. Just one question before Dr. Mahipal sets in the presentation. We do have a lot of patients with pterygium who have, a lot of significant corneal astigmatism also. So how do we tackle the patient with pterygium and cataract, sir?
Yeah, so if it is a small pterygium, which is just nasally there, and the astigmatism, say, assuming that the other eye doesn't have a pterygium, if the astigmatism in the both eyes is nearly the same, I just ignore the pterygium and then just go ahead with the conventional surgery. But if it is a large pterygium, and usually it's the flattening along the axis, that's in the steep axis, that the 0-180 degrees that takes place, and it is different from what is there in the other eye, I'd go ahead and do the pterygium excision, wait for a period of 2 to 3 weeks for the cornea to stabilize, remeasure the corneal astigmatism, and then decide whether the patient needs a toric intraocular lens or a non-toric lens.
Thank you. Now we invite Dr. Mahipal Sachdev, who is going to talk about converting the patient to premium cataract surgery, and I think that is the wave nowadays. People require a premium IOL surgery, so why not to convert them in all one go? And I think he will be the best person to talk on this subject. Dr. Mahipal, sir.
Thank you very much, Professor Titial. I'll be talking about understanding premium cataract surgery as to how to build it top tips and tricks. Well, as you all know that in recent years, phacoemulsification has changed the fundamental aim of cataract surgery from being a restorative surgery to a refractive surgery. That is something where we are looking at the patient's demand of the uncorrected visual acuity almost being similar to the best corrected visual acuity. And the name of the game has today become precision, has become emetropia, has become less dependence on glasses, etc. So that is what we have been talking about. And this is something that has evolved over time, and this is what we call today as the premium cataract surgery today. Now, when you are looking at premium cataract surgery, as has been said in the previous talks, you need to treat previous dry eye patients because they are going to be dissatisfied and your net promoter score for the patient satisfaction will go down. Corneal irregularities, etc., has to be seen, assess on the OCT that there are no macular changes which are there. And what is important is that you need to discuss the visual needs of the patient and the psychological assessment. So important when you're doing a premium cataract surgery is to manage expectations. Expectations in premium cataract surgery, I will say in two parts. One is the flax, which is nowadays available, and the second is the IOLs, which are available. And these are the two things that you have to do. That femtocataract, you need to inform the patient that any surgical intervention has a risk of complications, but this possibly reduces the outcome. It makes it more, reduces the complications and improves the outcomes and makes it more gentle on the eye. And in intraocular lenses, the word I use always is reduced dependence and not independence on glasses. So it will be reduced dependence on glasses and not independence of glasses. That is what you have to tell. In today's world, these symptoms have come down, but you must always warn the patient of glare, halos, starbursts, etc., and that should be told to them beforehand. And therefore, counseling is a key when you are looking at premium cataract surgery. It is mandatory to counsel all cataract patients. Pick the pleasant, people-friendly counselors which are there. Impart technical knowledge to your counselors because they should be able to give the best advice to the patient, and allow them to see and understand the femto procedure as also what the premium IOLs are going to give, like a toric or a trifocal, etc., and provide them audiovisual tools which are there. Now, these are the two things. So these are premium services. Biometry, keratometry, topography are important. But when you are looking at the next step, you need to create a core femto team. That means people who should talk, breathe, speak, eat femto. They should be able to tell the patients that this is a better procedure, what are the advantages, etc. So that they must be knowing, and this has to start from the right from the optometrist, the first point of contact, even up to the OT staff that is there, and tell the doctors that they need to learn femto. So I think the learning curve is pretty short, which could be 10 to 15 patients. Now, when we started femto, I think it was priced obnoxiously high. It was 50,000 rupees pricing over our normal charges of cataract, which are about 40,000. So the delta was more than 100%, and that hit us. So under the present circumstances, we reduced the prices once we switched over to the catalyst system, and we got a reduction in the LOI price, and therefore we were able to price it right. And that is something which is very, very important. But before making any investment in this technology, you should decide whether you are convinced by this technology. You should commit yourself and your team, and then you have to make sure that you have to succeed. Now, the premium service has to be given as a 360-degree experience. This is a normal dhabe wali chai, and this is Nescafe comes there. But when you go to Cafe Coffee Day or Starbucks, you know, there is a different experience, a different feel that you get. So therefore, a person who is coming in for a femto laser should be told which is the difference, what are the difference, what you want. Even the wow factor here of just holding the box of an iPhone is significant. So that is what the patient has to be done. So we make different discharge cards for them. We make them different places to sit. And what is very important is that when you have to start with a premium practice, you have to set goals, and what in layman term is called as gamify it. If your children get addicted to a video game, it is because they get points and they get prizes. So similarly, you need to gamify what you need to do. Set the targets that I need to do 100 femtos. We set targets of 100 femtos a month. Today we are at 600 plus femtos a month. But when you started the initial hiccups, we had to set targets and you had to gamify it and give rewards to the people that is there. And this is something very important, that net promoter score, that 0 to 6 are your detractors. That means after you have done a procedure, what does the patient talk about it? His experience has to be very good. And the people who are 7 to 8 are passives, and the promoters are 9 to 10. So average net promoter score should be about 72% in the Indian healthcare industry, and that is what you need to have. You need to go back and see that your net promoter score of the patients who go out are very happy. You should know how to share the success. So this is our every time we change these numbers. So this was in March, we crossed 675 femto cataracts in a month, and therefore we celebrated that as a success. And you need to share the success. This is just overall thing for the counseling, which is very, very important, that you have to believe that the counselors have to be patient friendly and give tips, etc. You can even have recorded voiceovers. You may have kiosks where a patient can click and get more things out of it. Testimonials are very important. Information letter, thank you cards, patient feedback forms, etc. These are again things which adds the value to what services you are giving. But always remember, under promise and over deliver, because the wow factor has always to be more than what a patient came in for. So 5 pillars for a premium procedure would be patient selection and counseling, planning, biometry and astigmatic management, precision with technology, giving your patient a premium experience, promise less and deliver more. So these are the things which can give you the success that you want in your premium practice. Thank you very much for your kind attention.
Thank you so much, Dr. Mahipal, coming from a person who has mastered the art of doing premium procedures and premium surgeries. Carries a lot of value. I am sure we could have had some discussion, but we are already running short of time, and the next batch is here. So thank you all so much for joining us for today morning's course. I think though the speakers came one by one, they all did an excellent job, and I enjoyed conducting this. I hope you enjoyed attending this as much as I did. Thank you all.